Hello, everyone. I am Delexia, and I'm a community resource and assessment specialist with Georgia Rural Health Innovation Center. And I have the pleasure of introducing our next speaker, Mr. Donovan Stevens. Mr. Donovan Stevens is the Deputy Director of the Opioid and Substance Misuse Program at the Georgia Department of Public Health. He is a native of Lithonia, Georgia. He holds a degree from Howard University and the University of Memphis and is currently pursuing his DRPH at the University of Georgia. With a background spanning medical research, urgent care, and services as an epidemiologist, Mr. Stevens has led efforts in outbreak research, emergency preparedness, and data modernization. Today, he is dedicated to reducing the burden of opioid use disorder and advancing health equity using his approachable communication styles to translate complex public health issues into meaningful, actionable strategies. So I present to you all Mr. Stevens.
Thank you so much for that introduction. Hello, everyone. Thank you all so much for this wonderful conference. It has been extremely informative, just listening to all of the different stories, meeting different folks who are here. So I'm going to try, we're at the end of the day after lunch is always a little timely, right? So I'm going to try not to be too long-winded. Again, my name is Donovan Stevens. Thankfully, this is our shortened name. Department of Public Health, it calls us the Opioid and Substance Misuse Response Program. Very long-winded. We're the opioid program. I'm going to talk about Google today just to keep things real simple. So if there's something that you have a question about, you can ask me, but you could probably also find some of this on Google. I know because I tested everything before I did it. So if you have more questions about our program, you can Google DPH opioid program. All right, so up here we have some of our objectives. They are not up here in any particular order, so I'm going to attempt to read them in the order of how we kind of prioritize them. First, we review reported data to identify opioid overdose hotspots and respond to clusters, establish a strong multi-agency approach to combating substance and opioid use disorder, establish linkages to treatment centers and harm reduction organizations, distribute opioid and prescription drug abuse educational and response resources, enhance the PDMP, and support syringe service activities. I think I was a little out of order on some of those, but we cover all of that. Here is our programmatic structure, and I have it set up like this as a wheel where we work our way out to in. It's all inclusive. Again, I speak about how important it is to have everyone that is here because it is a very multi-layered approach that we have going on. We can't have one component existing without the other. For us, our structure is really built on top of our grant. Our primary grant is Overdose Data to Action grant, which is with the CDC. It is primarily focused on utilizing data, turning that data into actionable solutions and interventions that can be utilized in the community. So we start with our logistics on the outside that keep us together, keep us organized, make sure we hit all of our goals. But moving our way into the circle, we have our surveillance team, also known as the Drug Surveillance Unit. And our drug surveillance unit does a really great job with keeping track of our fatal and non-fatal overdoses, as well as overdose syndromes that are coming into the hospital. So triage data, we're getting that. Discharge data, we're seeing all of that. And we really work with our public health analysts to help build a relationship with the hospitals. We'll get into detail with all of this in a bit. I'm going to do like an honorable mention of our lab team. I won't spend too long speaking about them and the work that they do, but they do partner with a few hospitals in the state, and we are looking to expand partnerships with hospitals. So if there's any hospitals in here, and if there's anything that I'm saying actually that interests any of y'all, please talk to me about it. Let's see how we could partner on it. But if there's any hospitals and you would like to partner with us, we are looking to collect more specimens so that we can test and get a better understanding of what our illicit substances are in the streets, if you will. And then we're going to move to our prevention team, which is typically where I spend a lot of my time. This covers our training, education, our web pages, our brochures, PDMP. I heard someone mention PDMP earlier. Our public health analysts, which are available to all of you. And then we have a lot of other initiatives that we'll take a look at as well. And they loop into our harm reduction initiatives. I'll say recently we've re-strategized how we were applying harm reduction in our team. Before it was just harm reduction, we had naloxone and fentanyl test strips. That was it. Well, recently we brought on surrender service programs, and instead of allowing them to just operate just where they are, we're having a more syndemic approach. I am an epidemiologist by trade, so we are working alongside TB, hepatitis, and Office of HIV now in our approaches as well. And then our evaluation really keeps us together in terms of making sure we're accomplishing our goals and we're doing the things that we set out to do. And on the inside, right there in the middle, are our PHAs, our public health analysts. And I need to edit this to add partners, because though we have our PHAs, they are great and phenomenal. They can't do what they do without their partners. So a little bit about our PHAs here. They're fabulous. I've heard the word amazing a couple of times, and it's like I could talk about them for forever, but they're just so amazing for all the things they do. And this is exactly how I feel about our PHAs. They are our boots on the grounds. What we do in our office, at the state office, it is great, but we're planning, we're putting together strategies. We're not the boots on the ground. We're not there with the community. Our PHAs are the extension from our office. They're tasked with creating a relationship, building a relationship with everyone that they have to work with in their jurisdiction. At Department of Public Health, we have 18 health districts. So that means we have 18 PHAs. They cover every county, 159 counties in Georgia. They have a PHA that is responsible for building a relationship with them. Sorry, I'm gonna move this a little closer. In building that relationship, they start with building strategic plans. So, cool, I'm at work, I can say, I would like to do this. It's a cool idea, right? But if I don't do anything with it, nothing happens. They have to build that relationship. They take their plan to their leadership, the health director takes it to the boards of health. They shop it around throughout the community to get a good idea of what is going on. How does everyone feel about this real actionable response? Then we have our ODMAP and we have biospatial, I should add up here. ODMAP is mostly utilized by law enforcement agencies as they're on the scene and they're responding to an overdose. They can enter in information about what they see on the scene. And we have biospatial, which is not up here, but that is often utilized by EMS. Law enforcement, EMS love them both, but the way that they describe what they see on the scene is completely different. So we like to collect both narratives, and we like to have a platform that allows for both agencies to provide the narrative that they like to provide. And then, as I mentioned before, building cross-sector partnerships. I have a list here. I want to make sure I hit everyone that they have to build partnerships with. Prescribers, pharmacists, first responders, treatment professionals, and I'm summarizing first responders, but again, law enforcement, EMAs, EMS. This is not the complete list here. Government officials. We have some PHAs who speak with the county mayor, the city mayor, the county government, county commissioners on a regular basis. There were opioid abatement dollars that were applied at the local level. When it comes to building those strategies and really getting an understanding of who's who are the different players, who are the community-based organizations, the RCOs, the treatment and recovery organizations that are available at the local level, our PHAs are those folks for us. So I brag about them. I talk about them a lot because if you do not know where they are, you should connect with them, and I would like to help you make that connection. Did I hit the wrong button here? I did. Sorry, y'all. All right, our surveillance strategies. Now, I'm not going to spend a lot of time today talking about data. We know that we have a problem, so I won't spend time diving into that. What I do want to talk about is what is available to you all. We have refined our data process, our data request process. Holly, I don't know if it's because of the opioid abatement trustworthy. We're getting data requests left and right. So we wanted to make sure that we can meet the demands of all of these different data requests that are coming in. So we have improved our process. If you Google Georgia DPH FIP PHIP, you'll be able to go there. That's how you'll make your data request. I'll give my information at the end of this presentation. If you need, we can walk you through it a lot better than that. Again, we're very hands-on. So if you reach out to me, I'll connect you with our epidemiologist, and they'll make sure you get what you need. If there's any stipulations or limitations to that data request, they'll let you know on the front end. We're refining this process. We've refined it on the technical aspect, the data aspect. Now we're refining it in the process. Some folks are submitting their data requests, but they're asking for a little too many details that kind of violate some of our stipulations. So to avoid that, we want to work with you on the front end if possible, okay? I keep hitting that button. All right, there we go. Did anybody else have that problem? Just me? Just me? Okay. All right. Our second strategy, morbidity surveillance. So this allows us to collect all of our syndromic surveillance data. Again, this is our emergency data, our discharge data, billing data. This is just really important. It gives us a preliminary idea of what is going on. Typically, we have to wait months to get our vital statistics data, our data from medical examiners and coroners. It takes a minute to get to us. So if we want to have an understanding of what is going on right now, if we have an overdose cluster going on right now, this data is the best data for us to utilize. And now we do have our EMS data that we finalize. I think it takes about 6 months for us to finalize our EMS data and some of our ED and discharge data. But once we have that data, we make it available in our reports. All of our reports can be found if you Google DPH Drug Surveillance Unit. Okay, so that's DPH Drug Surveillance Unit. It's a long page and there's a lot of reports in there, but I say that just so that if you have anyone that you need to inform, if you need to inform yourselves or your partners, leadership even, all of that information is there. And what you cannot find there, again, we can make available in a data request. All right, and our mortality data. So this is our state unintentional drug overdose reporting system, or SUDIS data. This data is also what is reported to CMS to CDC. So it is national available data. It becomes nationally available, but because you all are in the state of Georgia and here at this conference today, you're hearing about it now. That is also available on that web page. We look at our coroner's office death investigation management system, or CODEMS as we call it, as well as MDI log. Both are great for tracking death investigations, entering medical death investigation information at that time. Oh, and I said I wasn't going to talk much about data, but I did want to highlight the fact that our preliminary data for 2024, we're currently pulling our second half, last 6 months of 2024 data, analyzing that data. And what we're seeing right now is that our numbers are trending down for opioid overdoses and mortalities. So that is great news. We are seeing a little uptick in stimulants, but we still got to parse that out, look at it at better detail. But that is great news so far. And then I pulled this here just to pull something together to make it relevant. We don't have any data right now that is really specific to rural health or rural versus suburban versus urban or anything like that. So this did bring this to our attention, and we're putting some things together. We were able to put this together for you all. So I am an epidemiologist, but I have not been in charge of our data, so I'm gonna be a little rough and rigid right now. So if y'all have any deeper questions, please shoot me over an email and we'll make sure that we can get that answered. Looking at our rural and urban classification death rates by race and ethnicity here, when we look at the large central population, this is in Georgia, it's Atlanta, I'll say. This is the only population of this size. In that population, Black non-Hispanic persons had the highest rate of death within this population size. And then if we look at our medium metro population, is there a laser on here? Yes, if we look at our medium metro populations there, we'll notice that white non-Hispanic persons have the highest rate of death here. What is consistent is that white non-Hispanic and Hispanic persons' death rates and trends seem to be similar regardless of the population size. So we can look at that more and speak to that more. What we know is that symptoms of opioid use disorder, stimulant use disorder, they present themselves differently in different populations. The issue looks different in different populations. The response looks different in different populations. So I just wanted to provide a little bit of data for you all, but we're going to work to provide more context to this and kind of parse out what some of this means for us. All right, prevention strategies. And I feel like we probably have omitted some, but that might be good for the sake of time. Okay, yeah. All right, so right now we are working to partner with Alosa Health, which is a really great academic detailing vendor. And the goal here is to create and develop a evidence-based training that supports clinician in both pain management and opioid use disorder. We're still in the building stage. We haven't put the ink on the contract yet, but we're still looking for partners at local hospitals across the state to partner with. The idea is to develop curriculum around opioid use disorder training, similar to what CWC has done already. But we want to focus on rural populations, and we want to bring in an academic dynamic detailer for peer-to-peer training. So this is something that we have underway. I figured I'd add it in here in case it piqued anybody's interest in here, if you have any connections or if you know of a hospital outpatient organization, since that was mentioned earlier. That was a great point that was mentioned. Outpatient care organizations all are eligible. So we'd love to speak with you more to get more insight about how we can make this partnership a realistic thing. Additionally, we have CDC clinical practice guidelines that are made available on our PDMP. And we send out an annual PDMP survey and we advertise it there. But I think we can market it a little bit better. So we'll be advertising it continuously until we don't need to advertise it anymore. But we're going to improve how we market that to ensure that everybody is made aware of that information and has access to it. Additionally, our annual evaluations do a great job of informing us on our PDMP users. How well is it working for our clinicians? How well is it working for dispensers and prescribers, excuse me. We will continue this survey. Unfortunately, I don't have any data on this year. We had, I think we had around 4,000 respondents this year, which was great. Typically we get a little less than 1,000. So we pushed the survey very well. We can push our marketing of our clinical practice guidelines a little harder. So we've got some improvements there and a little growth to do. Our goal here with this strategy is to improve opioid prescribing, enhance patient care, and promote long-term practice change. We also want to support providers in making informed prescribing decisions while continuously assessing and improving practices to enhance patient safety. Again, I'm telling you all of this information in case anything here piques your interest. Donovan, I want to talk to you about this. We got something over here and what you talked about might work well with it. That's what we're here for. We're here to partner and network. All right, harm reduction strategies. So I made some last minute adjustments here. So I want to make sure that I am hitting on all of these topics. The video we watched earlier did a really good job, I think, of highlighting harm reduction. We know that it is a public health approach, and it's not always favored because it doesn't require abstinence. So one thing that I want to say is that while it does not require abstinence, it is an evidence-based approach that recognizes that people who use drugs deserve dignity, respect, and access to care. There are a lot of benefits in terms of it saving lives. I'm an epidemiologist. It prevents a lot of spread and transmission of infectious diseases. Again, we are partnering with our Office of HIV, Hepatitis, and Tuberculosis. And it also builds trust between the community, public health providers, public safety. We'll talk about this a little bit more as I go through some of our strategies specifically, but I just wanted to highlight some of the different benefits of harm reduction. Again, it sounds very nuanced. The video spoke specifically of the government purchasing pipes for users and things of that nature. Now, Georgia's not doing that. We can't do that, but we do support harm reduction initiatives and harm reduction strategies as much as we can. So again, if y'all have anything that you're working on, if you're receiving red tape, tell us about that. Let us know what your barriers and challenges are so we can learn how we can help facilitate you from where we are. All right, so I am not a lawyer. OCGA, whatever that is Wesley's Law. It is an amazing law that took effect on July 1st of last year. It requires all schools and government buildings to have an inventory of at least 3 doses of naloxone. And just this past year, there was a bill that went along with it that actually supported the purchase of the naloxone for those schools. So all schools in Georgia right now should not have any excuse to not have naloxone on hand at any school event. And that means football games. What other events are there? I just go to football games, but naloxone should be on hand at all times. We worked, in hand with DBHDD to get that out, especially to high schools that, had some suspected overdoses in 2024.
Donovan.
Yes.
We are working with the Department of Education to get naloxone and naloxone boxes into every school.
Okay, so still in development.
Not just we're actually doing it in the next couple weeks.
It would be here in a couple. Great.
I'll let you know.
Great. Okay. Yeah. There we go. All right, and so our goal here was just to support this effort. We developed a implementation policy to which we received a lot of calls from different government buildings and schools as to how can we make this thing work. In a nutshell, follow your AED policy that you already have is essentially what we did. So those naloxone boxes probably looks, yep, there we go. Awesome. And this link here again, if you Google, trying to think, I didn't test the Google on this one. Did I?
I can test the Google.
DPH naloxone. Thank you, Holly.
And I've only got one bar, so Again, naloxone, Georgia Department of Public Health, June 25th, 2024.
There we go. All right. So there's a little video there. There's some more, some additional information. And we should have some connections to help you find out how to get access to naloxone. Yes, our PHAs though, they're great, for being a great access for accessing naloxone. I'll talk about that a little bit more, but I just wanted you all to know that they are a connection for you, as well. We have not been prioritizing naloxone distribution amongst private, and for-profit businesses, just letting you know that. So we have to preface that more so for our high-risk organizations and high-risk populations, excuse me. But I'm just letting you know that because we get a lot of questions often by hospitals who want naloxone. And we unfortunately have to say no, but it is because we have to give it to folks who we know will not have the ability to make that purchase themselves or the access. Naloxone distribution, got a little bit ahead of myself. So I want to highlight here some of the great work that our PHAs have done with naloxone distribution in the past. We worked with DBHDD for them to receive 60 boxes of naloxone every quarter, and that was for each PHA in the state. So that was a large allotment that went out. Additionally, we sent out some. I can't remember exactly how many we provided, but in a nutshell, we distributed about 10,500 boxes of naloxone in about a year's time, which was great. It was great. It met so much demand. Now our community-based organizations know us to be the place that they can come to get naloxone whenever they are in need. They are very resourceful themselves, so they typically don't rely on us solely on us, but it's like if they're ever in a drought or having a tough period, they know they can call DPH, call one of our PHAs, and that resource is there. So we're very proud of that initiative, and we were able to take it a step further, and we developed a ReadyOp system, which allowed us to conduct ad hoc requests, allows our PHAs to do ad hoc requests, real-time requests on behalf of the community-based organizations that they partner with. So whereas before we sent it out on a quarterly basis, if they ran out, that was just it. They had to wait till that next quarterly shipment came. They're now able to order round the clock, round the year, and the shipment doesn't come to the PHA. It goes directly to the community-based organization so that they can get it in a much more efficient way. So we're very proud of that, and we're very proud to continue that. All right, our syringe service program. I got one slide up here about them. I probably should have had a bit more. Our syringe service program is fairly, I don't want to say it's new, but we really have just revamped it and launched it since COVID. It has been present, but it has not had any public facing acknowledgement. We didn't have a website until last year. So we've got a lot of growth going on and a lot of growing to do, but we're very happy for the work of our syringe service program. It was originally housed in our office of HIV, and they were kind of like, well, what do you want us to do? And I was like, I don't know, what do you want us to do? And so we ended up bringing on the harm reduction coordinator, and we work hand in hand with our office of HIV to ensure that we're meeting their goals of the Ending HIV Epidemic Grant, as well as our goals of the Overdose Data to Action Grant. It works great. It works well because it gives us a true syndemic approach to this. As our harm reduction coordinator works with syringe service programs, he's able to be very, very informal. Like they're friends, they're buddies. I'm like the boss's boss, so I have to like maintain a certain level of like, but he's like, what's going on, Jan? You doing good today? Like they have that level of relationship. So a lot of times they start off as SSPs, and then he's able to convince them or talk to them about wound care. He's able to talk to them about other diagnostic screenings like tuberculosis and HIV. And now we're widening that catch and the services that are being offered at that level. So we're really happy for the work that is being done there. As it relates to the SSP process specifically, our webpage now displays exactly how the application process goes. So if you want to Google DPH SSP, that will populate as well, and you'll be able to see exactly what that is, what are SSPs, how are they available, the different types that we have that are available in the state of Georgia. Right now, we are working to produce a map that displays that information as well. Someone mentioned, I think Jeff, you mentioned access. Where do you go? That's one of the biggest questions. So we're working on our end to create a very detailed map that displays where that organization is, where that person is. It's not always an organization. Sometimes it is Mary Jane down the block and she's like, hey, I've been through this. I'm retired. I just want to do what I need to do. And we'll take in Mary Jane, but we want to know what time are you open, Mary Jane? What time are you closed? Where can people go to actually find you? What is your contact information? So that is something that we are working on. Additionally, our harm reduction coordinator is very hands-on with the process. We don't want this to be anything that is too cumbersome. It is cumbersome. That's just it. It is written into law. We have certain checks and balances, compliance things that we have to meet. So we grab you by the hand. We walk you through it every step of the way. Before you even start the application, we're going to sit down, have a meeting with you and see what are your challenges. Do you have the capacity to do this work? Do you maybe need to look at a grant opportunity first before getting started? So we really work with all of our organizations through the challenges that we have. I believe in total we have about 23, don't quote me here, I think 23 organizations in Georgia. So we really want to display that information and make that accessible and encourage other organizations to do the same. I made mention of how organizations may start off as SSPs and then grow to wound care and other areas of diagnostics. But we also have organizations that work in the opposite. They already provide wound care. They already provide other services. And now they're like, well, we might as well go ahead and start doing needle exchange as well. Yes, that's exactly what we want to do. That works. But the question, what do we do next? Where do we go from here? Harm reduction can't stand alone. So we want to make sure that they're making connections with the treatment and recovery organizations, that they have connections with our PHAs. One thing that a new thing that we've done, our public health analyst, our harm reduction coordinator sends out a letter. He works with the organization, whoever the new SSP is. They send out a letter to law enforcement. He sets up a meeting with law enforcement, the SSP, the PHA, and another local community-based organization. We're going to have a conversation so that everybody is aware of the work that is going on. We have a mutual understanding. We have a certain level of mutual investment. Maybe not everybody at that table has that same level of understanding or same level of investment, but at least we're starting the conversation. They're legally protected, so we can't be told no once all of those boxes and checks are marked off. All right, and so our goal here is to enhance public health and promote community safety by reducing the transmission of infectious diseases and preventing overdose-related deaths. That's the goal of harm reduction right there, okay? The program collaborates with local law enforcement and community organizations to foster safer communities and promote long-term health outcomes throughout the state. Public safety strategies. All right, I'm going to try not to dwell too long here. We have an amazing public health analyst that we have at the state level. Special thanks to CDC Foundation for her. Miss Katie Freund, if you all know her. I think Ms. Thomas Forsyth. Yeah, there we go. She's amazing, does amazing work. This is one initiative that she works on with us, which is our prescription disruption response plan. We know that anytime a pain clinic is shut down, if a practice closes for any reason, be it maybe doctor shopping going on or simply a doctor has retired and they're closing their practice, the patients will suffer the most. So we developed this plan in the event that a group of patients will experience a disruption in their treatment. This response protocol is activated. The opioid program, we partner with law enforcement, DBHDD, and behavioral health agency to ensure rapid communication during prescription drug supply disruptions. The plan is designed to connect affected individuals with critical resources, especially when opioids are involved. PHAs play a central role here as well. They help share information with local partners and coordinating the response using established protocols. So I read that off of my notes, but I just want to tell you all just a little bit about all of the different partners that are involved here. This sheet is like 2 pages long and it starts at the state level. It is a large response anytime any of this happens. We want to make sure that we're responding accordingly. On our end, we want to make sure that we're providing the necessary education information into that community. DBHDD is involved. They're aware of what's going on just in case there's any increases in overdoses. Emergency departments are also made aware, as well as local law enforcement, so that everybody is prepared in the event that the response comes to that. I have not seen it come to that yet. I've been in this role for 3 years, so we've been doing pretty good. All right, so our opioid training, this may not be too specific for this group in here. Again, we do have that opioid training that is available if you Google DPH naloxone. But this training here has been made available for Georgia Public Safety Training Center, GIPSTIC, which is the center if y'all drove down from 85 from Atlanta, like I did, 75. You pass GIPSTIC on your way here, which is the center where just about all first responders in the state of Georgia train. We had a training available on their website and grew to be a bit outdated. It really only covered how to recognize and respond to an overdose. So just this past, I think April it was, we updated that training and expounded it to include polysubstance use and response, ACEs and stigma reduction, causes of opioid use disorder, and harm reduction. In total, I think the training is a little bit over an hour, but it has been made available for post-certification. So safety officers can take that training and receive additional accreditation. So yeah, just a tool that we have there. Again, it may not be specific for this group, but if you know of anybody who needs that training, you cannot Google this one, but please send me an email and I'll let you know more information on how to get access. All right. And I just wanted to highlight again, just the tremendous work that's going on again, Miss Katie Freund, and the work that she had with helping us with creating this training. It was recognized at the national level by the Overdose Response Strategy, or ORS, just for the amazing work that it does and how it's been made available. We just updated, I said April, so I think we updated it a little earlier than that, but we have had 210 first responders have completed the course already. And that number just continues to grow. So we're very excited about providing that education and knowledge and knowing that law enforcement and public safety officers have that knowledge and information available. Additionally, I want to highlight another great work that one of our PHAs and Miss Katie Freund worked on together. And this one here specifically was in Newton County. This is covered by our PHA that covers Gwinnett, Newton, and Rockdale counties, and he's been doing amazing work establishing OFRs in Gwinnett. Now he's moved on to do some great work in Newton County as well. I think this is actually featured on Channel 2 as well. I'm like, I can't go anywhere without watching my news, but I think I saw this one.
Can I point out that that was funded by the trust?
Yeah, it was.
Yeah.
There we go. See, another successful thing done by the Opioid Abatement Trust. So we're happy to have that. We're happy to have Tom as well. Look at all these things just coming together, y'all. So if y'all want to do something again with the PHA, let us know. Those are the type of things that they do. Anything there and in between, just about. All right, so I want to highlight some of our PDMP work. So this may bore some of you, but I didn't know how many clinicians we may have in the room, so I wanted to highlight some information that is here. Our PDMP, it is an electronic database that tracks our prescribing and dispensing of controlled substances. It provides prescribers and pharmacists with a patient's prescription history. It helps prevent duplicative prescribing and overprescribing of controlled substances. And the PDMP supports prescribers and dispensers in identifying patients at risk of substance misuse. We are regularly making changes and improvements on our PDMP. We have I highlight 3 projects here, but in honesty, y'all, we probably have 6 ongoing projects all simultaneously right now. We want to make sure that this is a tool that Dr. Mara, you made mention of it when you were speaking earlier. I don't know where she is. I'm probably missing her. But you made mention of utilizing the PDMP and having that connection to other states. So our PDMP does connect to all of our bordering states, and we connect to 19 other states as well. I think that's 24 in total. So we're working regularly to expand that list to ensure that we are sharing data with more than just those 24 states. What that does is ensures that if you have a patient that has now moved or relocated, that you're operating in good faith as you prescribe them. You know what their prescription history is. You have an opportunity to view that and make the best decision. We're also working to include additional tools and resources in the PDMP that help with making those decisions. We don't want to make that decision for you all, but we want to help with aiding and making that decision. I don't know if you all know of NARCS Care and things like that, which is a PDMP tool that may be available in other states. I think certain healthcare vendors may have it, but we just want to make sure that we're giving you clinicians the information that is necessary and the tools as to how to make the best decisions. All right, the purpose of the PDMP is to improve opioid prescribing patterns in Georgia. For each quarter and year, we publish a report. Our other purpose is to establish and maintain system functionality and data integrity. And our last purpose here is to support the needs of prescribers, dispensers, and patients. DPH, we have several key functions that keeps our PDMP running smoothly. First, our PDMP support team, phenomenal team of 2 ladies. They handle calls for the entire state. So as clinicians often have issues with getting into the system, maybe their account has been deactivated because they failed to update their password. Our PDMP support team takes care of them and makes sure that they get all their issues handled. Next, our PDMP epidemiologist does a phenomenal job of tracking our prescription data. We're throwing a lot of last minute changes at them lately. We want to track more and more data, and so we're paying attention to other data that is of interest to other states, as well as data that is of interest to clinicians. So recently we've included, originally it was just opioids, so now we're tracking buprenorphine a lot closely, as well as stimulants. And we're looking at some other prescriptions a lot closer as well. We're doing a little analysis before we are sure to include them in our reports. But I just want you all to know that we have that view and that perspective, and ensuring that we're providing you all with useful information. We have our PDMP evaluator who looks at our survey data that goes out annually to make sure that the PDMP is useful. Is it user friendly? We made this change, but do y'all like it? Does it work for you? So we have that going on annually. And finally, our opioid program develops education and communication tools to help prescribers and pharmacists use the PDMP effectively. All right. Certain prescribers are considered high risk because they can put patients at greater risk for opioid use disorder. We spoke about that a little bit earlier. It's kind of like comparing apples and oranges to oranges. If I have an oncologist versus a pediatrician, right? You want to make sure that you have an opportunity to compare opioid prescribing use on a more qualitative friendly environment. Sorry, I'm tripping over my words there. If it helps y'all, I had COVID like 2 weeks ago, so I got a little fatigue, a little cough, and a little brain fog, I guess. Data from the PDMP are used to educate our partners and inform prevention efforts across the state. These are the data that we have that are made available, but again, y'all, we have expanded this list, so these are just a few that I've highlighted up here. PDMP for prescribers. It is mandatory for all prescribers that hold a professional license and an active DEA number. A lot of times we get prescribers who just want registration into the system, even though they're not prescribing controlled substances. We'll let you, but I mean, do you need to, right? You have to have a DEA. So then do you want to go through the hassle of acquiring a DEA as well? We are doing work, right now to see what we can do with gaining access, permitting access for our medical examiners and coroners. Georgia law is a little interesting there. So we've got some finagle room if you have a DEA number, but not many medical examiners have DEA numbers because they don't prescribe medication. So there's some value added to that, just to having a complete patient report. It would give the medical examiners an opportunity to include additional information in there. Additionally, a prescriber is required to check the PDMP before writing a prescription for the first time for benzodiazepines, opiate drugs, and cocaine derivatives listed in Schedule 2. And thereafter, if the prescription continues, the prescriber should check the PDMP at least every 90 days. PDMP does a really good job of having different alerts in the system that notify the prescriber if some of these things are not being done, or if anything just looks a little wonky with these. All right, PDMP for prescribers continued. Prescribers are not required to check the PDMP if the prescription is no more than a 3-day supply. This typically applies for emergency departments. If the patient is in a healthcare facility like a nursing home. Recently, someone asked about incarcerated settings. That applies to incarcerated settings as well. And the patient, if the patient has had outpatient surgery or the patient is receiving treatment for cancer. All right, and PDMP for pharmacists, pharmacies, and the patients. Pharmacists, any prescription for a Schedule 2 through 5 substance must be entered into the PDMP within 24 hours of being dispensed. So this is kind of how the PDMP pharmacists and prescribers work together. Prescribers check the PDMP before prescribing. Pharmacists make sure they enter in that information. The pharmacist isn't accurately entering in that information. The prescriber isn't viewing accurate prescription information. So pharmacies are also required to enter in information even if it is what we call a zero report. So if they don't have any data that day, they still have to submit a report. If they are closed that day and they have not submitted a waiver to exclude them to not report on the day that they are closed, they must submit a zero report. So it is very stringent and a lot of compliance features are in place. But again, this ensures that our prescribers are viewing accurate data and it's timely. And last but not least, the patients. How dare I forget the patients? Patients themselves have the rights within the PDMP. They can request a copy of their own prescription history if they want to review it. They want to review who is accessing it as well. All right, so some PDMP tools here. I highlighted a couple earlier when I mentioned clinical alerts. This provides notification and alerts to prescribers to indicate that one of their patients has met or exceeded one of these thresholds here. So we have daily active methadone, daily active MME, consecutive opioids received for greater than, in Georgia, we have 90 days and 3 prescribers and 3 dispensers I think we're at 60 days in Georgia. So we can change these parameters and we do so based on what our, again, data to action, what our data tells us we should do is how we make these parameters. But right now, those are the options that we have available in the state of Georgia. It certainly helps prescribers in identifying or at least questioning. Again, this is not a judgment call. This doesn't say you received this alert. This patient doesn't need their opioid medication. That's not what we're saying. We're saying take another look, see what's going on, ask some questions, create that conversation. All right, and another PDMP tool that we have, which is pretty cool, is our prescriber report cards, which are designed to give prescribers meaningful insight into their own prescribing patterns. They help prescribers reflect on how they're prescribing controlled substances and how that compares with their peers across the state. So that's what I was mentioning earlier with the apples to apples and oranges to oranges. Right now, it doesn't really give us that view of apples to apples and oranges to oranges. It just gives you a view of all of your peers. So if you just throw me in the pot, I'm able to compare myself against other specialties and things of that nature. So we have a project that I'll talk about in a second that addresses that. But to receive this report, the prescriber, this is the only caveat, they have to enter their specialty into the system. Most people register for the PDMP. They're just trying to hurry up and get it over with and get it done, and they always skip their specialty. And so 6 months down the line, they're like, hey, I'm not getting this. This was the whole reason I signed up. It's because they didn't enter their specialty. So that's something that we always have to remind prescribers of. But again, if you all know of prescribers, they're not utilizing the PDMP, they don't know that they have this, please let them know, give them my information, and we can talk about this into greater detail. I wanted to include, and it's not really big, it's kind of my test run. I wanted to see if it could be seen. It's a little difficult to see, but I'll just talk about what's up here. So again, this is the comparison. It has all of the prescribers' information up here. The specialty is here, and it lets them know exactly what their patterns are, what their prescribing rate patterns are. And when we get down here on the sides, we're able to break it out. We're looking at opioids, benzodiazepines, sedatives, and then stimulants. And then down here is a more comparison of themselves to other peers in a certain geographical pattern, geographical region. Okay. And then they also have their delegates. So if there's anyone that is prescribing on their behalf as well, that information will populate down here as well. So again, a very powerful tool, but right now we are working to do some things where we refine this to be a more apples to apples and oranges to oranges comparison. PDMP integration. This is one great tool. We typically don't talk about this often, but I wanted to let everybody know, and I didn't put it in here, and if I did, it would have had like flashing lights, but this is a free tool for independent pharmacies and EHRs. What it does is essentially it prevents you from having to exit your EHR or your pharmacy management system to go check the PDMP, adding additional time to your clinical workflow. You could just have this process integrated within your workflow. It makes it very simple, makes it easy, and it kind of increases usability. It does. Our facilities that we've conducted analysis on that have who have utilized integration, their prescribers are using the PDMP. Not saying that those who have not done integration aren't, but our data shows us that there's just greater likelihood that once they have integration, they will use the PDMP. Again, this is free. If you are a part of a larger healthcare system, unfortunately, I think our Piedmont, Wellstars, Emory's, I think they have their own agreement with our vendor. But for our independent pharmacies and our independent clinicians, we do provide this for free. So again, get my information. We could talk about that more. Actually, you can Google this one. If you Google PDMP integration, DPH, this will pull up as well. All right, so that healthcare system prescriber dashboard, that apples to apples, oranges to oranges view that I was talking about, we're currently partnering with Piedmont Healthcare System and our vendor, Bamboo Health, our PDMP vendor, Bamboo Health, to work on this dashboard that just gives us that more accurate comparison. One thing that when I started here, I realized I was like, well, this is a pediatrician. And now I'm looking I think I was looking at a pain management specialist. I was like, well, of course the numbers are different. They should be different. But how can we make sure that prescribers have that information in a useful way? So we're working now to develop a threshold that kind of gives you a better idea. Dr. Mara, orthopedist as well. That'll be its own view, being able to compare yourself against other orthopedists, more accurate comparison in terms of peer-to-peer view. All right, so that's something that we are very excited about. More licensing integration. We want to automate our process with our PDMP, make this a lot more user-friendly, a lot more timely. So if you're a clinician in here and you don't know, which you probably don't, we probably will be disrupting your service at some point in time. So just a heads up there. It will be a very, very short disruption, like within the day and resuming within the same day. But we're making improvements to our system. We're integrating our data directly from our boards of pharmacy, directly from our board of dentistry, optometry, nursing boards, all of those partners that we have, just to make this process a lot quicker, and to improve the security of our data. Overall impact, it supports compliance, it enhances our system security, provides deeper specialty level insights into prescribing behavior, and it lays foundation for more proactive and data-informed PDMP governance in Georgia. So that's one of our biggest goals there, and we have it highlighted 3 projects, but we have it undergoing across about 6 projects right now. All right, just a little bit about our PDMP data and trends. Again, I don't want to bore you all too much with data. Over the last 5 years, we've seen some clear shifts in prescription trends. Opioid prescriptions have steadily dropped, demonstrating a 12% decline across the displayed drug types here: opioids, benzos, and stimulants. Benzodiazepines declined slightly, going from 3.3 million to approximately 3 million over this period. On the other hand, stimulant prescriptions have been rising every year, climbing from 3.3 million in 2020 to 4.4 to 4 million in 2024. This represents a 21% increase. We don't, and I added this as a caveat here because we are not sure that this is indicative of an increase in prescriptions. We are still having an increase in prescribers that are still joining the PDMP. So we need to continue to run analysis to get better understanding there. Overall, we're seeing fewer opioid and benzodiazepine prescriptions, but still a steady rise in stimulants. Again, additional analysis is necessary there. All right, looking at our quarterly data from mid-2022 through 2025, we see some clear patterns. Our opioid prescriptions are slowly trending down, though there are some small fluctuations. Benzodiazepines, again, are also gradually declining here on this quarterly basis. Stimulants, again, we see right here towards the end, it's just a little bit that opposite story. So more work needs to be done there. We need to see what's going on with stimulants. I think we need more investigation on the prescription side as well as the illicit side. And I think others in the room probably agree there. All right, looking at some more data. I think we got one more slide of data, y'all, so I hope it's not too much. All right, looking at opioid prescriptions in Georgia for quarter two 2025, we see two important patterns. First, women receive more opioid prescriptions than men at about 59%. And then secondly, our prescription rates increase dramatically with age. Very low amongst children. Again, I mentioned the pediatric group, and then climb sharply after age 45. The highest rates are in the 75 to 84 age group. You made mention of that earlier as well. So there's more work that we have to be done. There's more areas that need to be addressed. Overall, this shows that opioid prescribing is concentrated among older adults and more common among women. So just food for thought. All right, looking at county level data here, we see that opioid prescribing is not evenly distributed across Georgia. Looking at this data, there was not a lot that initially stood out to me. What we did notice was that the highest prescription rates are concentrated in the southern and southeastern parts of the state, with some counties exceeding 250 prescriptions per 1,000 residents. In contrast, Metro Atlanta counties have some of the lower rates in the states. So perhaps we can draw additional attention towards rural prescribing patterns. When we look at the year-over-year change, nearly all counties show a decline in prescription counts compared to 2024. However, there are a couple of counties denoted in pink that actually saw increases. Perhaps some intervention is necessary. All right, so my takeaways, the call to action, I wanted to make this specific for this group. Again, why am I up here? Why am I talking for an hour? Call to action, recognize, respond, and refer. We want you to improve access to resources. Not we want to improve access to resources. It takes all of us. The PDMP is a resource. Your PHAs are a resource. You all in this room are a resource to each other. Linkages to care need to be increased. We have to build our continuum of care, and it's a multi-layered approach. We have to increase our linkages to care in order for that to happen. We got to work on getting more beds in order to make that sustainable. Sustaining community support, understanding what we have beyond just our community, beyond our clinical settings. Our RCOs, our CBOs, those boots on the ground, grassroots organizations that are doing the work, they have to be included in the conversation. Nothing for us without us is a phrase that is often used amongst this group. Just the same, they have to be invited to the table, have a seat at the table with these conversations. And this is the big one here. Establishing a continuum of care, full wraparound service. We have to make all of this work. I think that's why I use that wheel that we saw at the beginning, because it keeps going. It never stops. One thing feeds into the next, and we all work together collaboratively to make this happen. All right, so here's my information. Thank you all so much for your time today. Please take a picture, shoot me an email. I do have a phone number there, but it is ringing like crazy right now. So please shoot me an email, and I'll be sure to get back to you, answer your questions, connect you with whoever you need to be connected with. Do we have time for questions and answers? Yes. Okay. Awesome. I'm taking them. Yes.
The slide that was prescriptions by drug type and year. It is interesting. You referenced stimulants went up every year, but opioids went down every year. Is there a medical connection between those?
I'm not sure. I'm wondering though. I'm wondering if there was some co-prescribing that was going on, or some changes in co-prescribing that was going on. So we're looking into that. But yeah, we're very interested in seeing exactly what is going on. Yeah, and also mentioning that there's been an increase in illicit stimulants available on the street as well. It's just something to be very mindful of. Yeah. Yes.
Quick question. Hello? Quick question. Prescribers, are they required to enroll in the PDMP yet, or is it?
If they have a DEA number, yes. And so the idea is that if you have a DEA, you're prescribing controlled substances 2 through 5. If you don't have a DEA, you're probably not prescribing. And if you are prescribing, you need to have that DEA number. Yeah.
Okay. That was the question.
Okay. Thank you.
Hi, my name is Dr. Daniela Sullivan Marzal. I've got a question. I'm not an MD, I'm a PhD. I know we're talking about opioids and whatnot, but I'm really curious about the increase in marijuana and what they're putting in the marijuana because of the schizophrenia and things that are being triggered, especially in young people. So I didn't know what we're looking at or if you have any data.
We have data, I would say specifically on kratom, which is the only other, I'm trying to think of the word there, adulterant that we're looking at that might be found in marijuana so far. We are looking at nitazines, mitazines. We have so many other different drugs that we're looking at. We typically bring them up when they become more of an issue or drug of concern. Right now, there hasn't been a lot of that just yet. There's a lot more developing in the medical marijuana field, as well as different studies that I think are necessary to understand some of the outcomes of medical marijuana usage. So I'm not sure of what is being done in that field right now, but I will take it back, ask some questions, and I'll see where we can do our part with overlapping studies.
Thank you.
Yeah, thank you. Give me one. I'm pulling out my phone to take notes, y'all. I'm not sending a text.
Great presentation, and thank you for being here. What is the protocol process for when you see physicians that are overprescribing? Is there a protocol in place?
There is not currently. And the first step for that was developing that threshold, giving us an idea of how do we flag a physician? How do we first bring it to their attention, give them an opportunity to kind of make some corrections, create a more of an educational opportunity versus a punitive approach to it. So our first step is developing that threshold. Once we get that, and we're looking at national numbers as well as state numbers, we're using Piedmont, and fortunately, we thought we were just getting one hospital. They enrolled all of their facilities. So now we have a larger net to cast for those different specialties. And we also have our national partners as well. We partner with every state. We talk to just about every state, except California. They got some weird laws going on. But we work with them to get an understanding of those different prescriber thresholds for those specialties. So we'll be making comparisons to get an understanding of where we should have our prescribers in Georgia. When they hit those thresholds, then we'll have to create our protocol for what we'll do next. But yes, that is where our thinking is.
And are you monitoring dentists as well as doctors?
We are monitoring dentists. You said something earlier that brought something to my attention. I'll talk to you about it later. Thank you. Any other questions, y'all? Okay, awesome. Thank y'all so much. Thank you for having me.